That sudden searing pain, like something just ripped apart inside you. We've all experienced, some version of that intense, immediate agony. Today, we're diving into a condition that can feel exactly like that, but with life-threatening consequences, aortic dissection.
Yeah, but its most fundamental aortic dissection is a tear. It's in the innermost layer of the aorta that's called the intima.
The intima, okay.
Think of the aorta like a multi-layered pipe, right?
Right.
This tear allows blood to surge, and with tremendous force between the intima and the next layer, the media, it basically creates a new false channel for blood flow.
And this is a major health crisis we're talking about. Our deep dive today is based on expert-level insights from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. And this condition isn't exactly rare, is it?
No, not at all. It's actually the most common catastrophic event to affect the aorta. It's even more frequent than, say, a ruptured abdominal aortic aneurysm.
Wow.
Precisely. And the stakes are incredibly high. Without prompt and appropriate treatment, the vast majority of patients with aortic dissection, sadly, will not survive beyond about 3 months.
3 months.
Yeah. And in fact, the data paint a stark picture. Within the first, 6 hours without treatment, mortality could exceed 20%.
Just 6 hours?
Yeah. It rises to 50% within 24 hours and close to 70% within the first week. That's how critical timely intervention really is.
Okay, let's unpack this serious situation. Our mission today, drawing directly from this authoritative source, is really to give you a clear understanding of aortic dissection. We'll look at how it's classified, who's at higher risk, how it might present itself, and the significant advancements in treatment. We really want to provide you with the essential knowledge without getting too bogged down in, excessive medical jargon.
And what's particularly interesting, I think, is how our approach to managing certain types, specifically type B aortic dissections, has evolved quite significantly over the past decade or so.
Yeah.
This shift really highlights the dynamic nature of medical knowledge and, well, why understanding these changes is so important for both clinicians and, frankly, anyone interested in the topic.
Absolutely. So let's get into how doctors categorize these dissections. It's not just about where the tear is, right? There's also a timing aspect.
That's right, yeah. We first consider when the dissection occurred. If it's within the first 2 weeks of the symptoms starting, we classify it as acute.
Okay, acute, 2 weeks.
And this initial period is critical because, well, a large proportion of deaths unfortunately occur during this time.
Right.
Then, from 2 weeks up to 90 days, it's considered subacute.
Subacute.
Okay.
And interestingly, this subacute phase is often seen as an optimal time for certain treatments, like elective endovascular repair, something we'll definitely talk more about later. It's because the dissected layer of the aorta is still relatively, flexible.
And then anything beyond that 90-day mark is considered chronic. Exactly. By this point, the dissected aortic wall has stiffened up quite a bit, and the aorta itself begins to sort of adapt and remodel. This can have both good and bad consequences over the long term. So this temporal classification, acute, subacute, chronic, combined with precisely where the dissection occurs along the aorta, that helps guide the treatment strategies.
Okay. Now, when we talk about the location, you mentioned there are 2 main classification systems doctors use, DeBakey and Stanford.
Yes, that's right. The DeBakey classification, which came first back in 1965, it provides a really detailed anatomical description. It's based on where the initial tear occurs and how far the dissection actually extends along the aorta.
Okay.
So type I starts in the ascending aorta, that's the part closest to the heart, goes through the aortic arch, and continues down the descending aorta.
So it covers a lot of ground.
It does. Type 2 is confined just to the ascending aorta. Then type 3 originates in the descending aorta and stays within the chest, while type 3I also starts in the descending aorta but extends further down into the abdominal aorta. So the DeBakey really maps out the whole path.
Okay, so DeBakey is very granular, very detailed about the extent. How does the Stanford system differ then?
The Stanford system, which came along a few years later in 1970, takes a more simplified approach. It focuses solely on the origin of that initial tear.
Just the origin.
Just the origin.
Yeah.
So type A dissections are those where the tear originates anywhere in the ascending aorta. This category actually includes both DeBakey types I and II.
Ah.
Okay. Then Stanford Type B dissections are characterized by a tear that starts in the descending aorta, specifically distal to the left subclavian artery. That's an artery branching off to the left arm.
Got it.
And Stanford Type B basically encompasses DeBakey types 3 and IBA. So Stanford's main distinction is simply, is the ascending aorta involved or not?
And you mentioned that the Stanford classification is more commonly used to guide the initial treatment decisions. Why is that?
Because whether the ascending aorta is involved, which is what defines a Stanford Type A, is really the most critical factor influencing those early outcomes.
Okay.
Type A dissections carry a much higher immediate risk of life-threatening complications affecting the heart itself. Things like a rupture near the heart or blockage of the coronary arteries.
So it's about proximity to the heart, essentially.
Exactly. Therefore, identifying a Type A dissection triggers a much more urgent response, often involving immediate surgery.
That makes immediate clinical sense. But our source also points out a limitation, maybe a gap in these classifications, specifically regarding tears that originate right in the aortic arch itself.
Yeah, this is a really interesting area where the classic Stanford A and B categories don't perfectly align. Dissections that begin in the aortic arch, sort of between the vessels that supply blood to the head and arms,
Hmm.
well, they present a bit of a challenge.
How's-
Well, typically, cardiac surgeons, whose primary focus is the heart and the ascending aorta, might consider anything beyond the innominate artery that's the first major branch off the arch as basically a Type B.
Okay.
Their focus for a Type A is usually on replacing the ascending aorta itself. But vascular surgeons, who often deal with the aorta beyond the heart, might view anything before the left subclavian artery as effectively a Type A.
Why the difference?
Because of the technical complexities involved in either open surgery or placing stent grafts right there in the arch. It's tricky territory.
So it sounds like there can be slightly different perspectives depending on the medical specialty involved, almost a gray area.
Exactly. And this difference in perspective really underscores the vital importance of a collaborative, multidisciplinary team approach when managing aortic dissection. You often need the combined expertise of both cardiac and vascular surgeons to figure out the best treatment strategy for these arch-originating dissections.
Okay, that's really important context. Let's shift our focus now to who is actually at risk for developing an aortic dissection. What can the study of its occurrence, the epidemiology, tell us?
Well, epidemiological studies estimate that aortic dissection affects about, let's say, 2.9 to 3.5 individuals per 100,000 people each year. So it's not super common, but not vanishingly rare either.
And it affects men more.
Yes, it's definitely more prevalent in men. The male-to-female ratio is roughly 3 or 4 to 1.
Wow.
As for the types, Type A dissections are slightly more common, maybe around 60% of all cases, and they tend to occur most frequently in people in their 50s and 60s.
And Type B.
Type B dissections are seen a bit later, more often in individuals in their 60s and 70s.
Okay, and what are the major underlying risk factors that increase someone's susceptibility? I assume high blood pressure is on the list.
Oh, absolutely. High blood pressure, hypertension is a significant one. It's present in approximately 72% of patients, according to the data in our source.
That's a huge percentage.
It really is.
Yeah.
Interestingly, there also seem to be some chronobiologic patterns.
Chronobiologic, like time-related.
Yeah. Aortic dissections tend to occur more often in the morning hours,
Yeah.
typically between 6 a.m. and noon, and also more frequently during the winter months compared to summer.
That's fascinating. Any idea why?
The reasons aren't fully understood, but it might relate to natural fluctuations in blood pressure or other physiological changes that happen during those times.
Interesting. Are there any pre-existing structural issues with the aorta itself that increase the risk? Things someone might be born with?
Yes, definitely. There are several. A bicuspid aortic valve, where the aortic valve has only 2 leaflets instead of the usual 3, that's a well-known risk factor.
Right.
And that's often associated with a dilation or widening of the aortic root, the part of the aorta closest to the heart.
Okay.
Other structural conditions include things like coarctation of the aorta, which is a narrowing, annuloaortic ectasia, where the valve ring and root are enlarged, certain chromosomal abnormalities like Turner and Noonan syndromes, aortic arch hypoplasia, where the arch is underdeveloped, and importantly, hereditary connective tissue disorders.
Like Marfan syndrome.
Exactly. Marfan and Ehlers-Danlos syndromes, which weaken the aortic wall itself. Marfan syndrome is particularly noteworthy as a risk factor in younger patients, people under the age of 40.
What about specific conditions or events, like pregnancy? Does that increase risk?
It does. Pregnancy increases the risk of aortic dissection by about 4.
Fourfold. Wow.
Yeah, although it's important to remember it's still a relatively rare occurrence overall, maybe 5.5 per million pregnancies.
Okay.
Preeclampsia, that condition with high blood pressure during pregnancy, is a significant contributing factor. And pregnant women who already have Marfan syndrome and a dilated aortic root are at particularly high risk.
And where do these tend to occur in younger people?
In younger individuals, including during pregnancy, dissections are more likely to involve the ascending aorta, often near the sinuses of Valsalva, those little outpouchings at the base of the aorta.
I was also surprised to see cocaine abuse listed as a risk factor in our sources. Is that common?
Well, the overall incidence linked to cocaine use is relatively low, maybe around 1.7% in one large study. But it can be a much more significant factor in certain urban populations.
Right.
Some reports show rates as high as 37% in specific settings. The typical patient profile there is often a young male who smokes and already has high blood pressure.
And how does cocaine cause it?
The thinking is that cocaine triggers a massive surge in catecholamines hormones, like adrenaline. This leads to a dramatic and rapid increase in the force with which the heart contracts, putting extreme sudden stress on the aortic wall.
Okay, so we understand that a tear kicks this whole process off, but what does the actual physical damage, the pathologic anatomy, look like inside the aorta?
Right, so the intimal tear itself is the critical defining event. It's usually a transverse tear, meaning it runs across the aorta rather than along its length.
Across, not along. Okay.
And it doesn't typically go all the way around the circumference. This tear creates the entry point for that high-pressure blood to basically dissect or split between the layers of the aortic wall, specifically between the intima and the media, forming that false lumen, that new channel.
And does it stop there?
Not always.
Huh?
Downstream from the initial tear, secondary tears, called fenestrations, can develop. These often happen near the openings of branch vessels.
Fenestrations, like little windows.
Exactly like windows. These fenestrations can allow blood to flow back into the true lumen, or they can just maintain blood flow within the false lumen itself. The intimal flap, that thin wall separating the true and false channels, that's really the hallmark you look for on imaging.
And where along the aorta do these initial tears most commonly happen?
The ascending aorta, the section closest to the heart, is the most frequent starting point. That accounts for about 65% of initial tears.
2/3, basically.
Roughly, yeah. The descending aorta is the origin in approximately 25% of cases. And the aortic arch or the abdominal aorta are less common starting points, making up the remaining 10%.
And is there a specific spot in the descending aorta that's common?
Yes, interestingly, in the descending aorta, the tear often occurs just beyond the left subclavian artery. That area is thought to be particularly vulnerable, probably due to the significant pressure fluctuations that occur there as blood is ejected from the heart and hits the resistance of the peripheral circulation. It's a point of high stress.
Our source also mentioned a typical anatomical pattern, especially in type B dissections.
Yes, in a sort of classic type B dissection, the false lumen typically runs along the left posterolateral aspect of the aorta, so the back and side.
Okay.
And the major arteries supplying the abdominal organs, the celiac and the superior mesenteric artery, as well as the right renal artery, they often continue to originate from the original or true lumen.
But not always.
Right. Sometimes, for example, the left renal artery might arise from the false lumen. It's really important to emphasize that these are just the most common patterns. Significant anatomical variations are frequently encountered in real patients. You have to look carefully at the imaging for each individual case.
Got it. And what about this term cystic medial necrosis that our source refers to? What exactly is that happening in the aortic wall?
Yeah, cystic medial necrosis, or sometimes just called medial degeneration, refers to a weakening and breakdown of the middle layer, the media of the aortic wall.
The middle layer.
Right. The structural proteins in there, the collagen and elastin, they give the aorta its strength and elasticity. They become disorganized and degenerate. This weakening of the aortic wall is believed to be a key predisposing factor in most aortic dissections.
And it's linked to those genetic conditions.
Yes, it's a prominent feature in hereditary connective tissue disorders like Marfan and Ehlers-Danlos. But importantly, it can also be present to varying degrees in individuals without these specific conditions. It might be linked to just the cumulative effects of aging and chronic hypertension, putting stress on the aortic wall over many years.
Okay. Now, a potentially devastating complication of aortic dissection is something called malperfusion syndrome. Can you explain what that entails?
Absolutely. Malperfusion syndrome occurs when the aortic dissection disrupts the normal flow of blood to one or more vital organs. This leads to ischemia, basically, a lack of oxygen and nutrients reaching the tissues.
And it can affect multiple organs.
Yes, it can affect various vascular beds simultaneously, the kidneys, the intestines, the legs, even the spinal cord. And the initial signs can sometimes be subtle and difficult to recognize, which makes it dangerous.
How common is it?
It's a very serious complication, occurring in up to about 31% of acute aortic dissections. And unfortunately, it's associated with significantly higher rates of early mortality.
So how does the dissection actually impede blood flow to these critical arteries branching off the aorta?
Well, several factors contribute. The sheer extent of the aorta that's dissected matters, of course. The presence and location of those fenestrations, those re-entry points where blood can flow back from the false lumen into the true lumen, also play a role. And the precise relationship of the branch vessel openings, or ostia, to the true false channels is critical. What often happens immediately following the initial tear is that the original, or true, lumen of the aorta collapses to some degree, while the newly formed false lumen expands.
That seems a bit counterintuitive. Why would the true lumen collapse? Shouldn't it stay open?
Yeah, it does seem odd, but it's related to the biomechanics of the aortic wall. You can think about it using the law of Laplace. Essentially, the outer wall of the false lumen, which is supported by the outermost layer called the adventitia, needs to expand to accommodate the high-pressure blood flowing into it.
Right.
The true lumen, which contains more of the elastic components of the aortic wall, tends to sort of recoil and become compressed by this expanding false lumen,
I see.
especially if there's a large initial tear and maybe limited points where blood can re-enter the true lumen further down. The pressure inside the false lumen can become significantly higher than in the true lumen. This pressure difference further compresses the true lumen, restricting blood flow to the organs that branch off it.
Okay, that makes more sense. Our source details two main mechanisms by which this branch vessel blood flow can be compromised: dynamic obstruction and static obstruction. What's the key difference between those two?
Right. Dynamic obstruction is the more common of the two, maybe around 80% of cases. It's kind of like a temporary or intermittent blockage.
Dynamic meaning it can change.
Exactly. The true lumen might be compressed by the high pressure in the false lumen, just like we discussed, to the point where it can't deliver enough blood to a branch vessel. Or that intimal flap, the dividing wall, might actually prolapse or flap into the opening of a branch vessel during the pulsal flow of blood with each heartbeat.
So the vessel itself is okay, but the flow is blocked.
Precisely. Yeah. Importantly, in dynamic obstruction, the branch vessel itself is anatomically intact. The severity of this type of obstruction can fluctuate. It depends on things like how much the aorta is dissected, the heart's pumping ability, cardiac output, the patient's blood pressure, their heart rate, and the resistance to blood flow in the vessels further downstream.
And you mentioned pulse deficits.
Yes, a key characteristic of dynamic obstruction is that pulse deficits in the affected limb or organ, like a weak pulse in the leg or arm, can sometimes come and go as these dynamics change.
Okay, so that's dynamic. What about static obstruction?
Static obstruction represents a more direct and, well, fixed physical blockage. In this scenario, the dissection actually extends directly into the wall of the branch vessel itself, causing a physical narrowing of its lumen.
The dissection goes right into the branch.
Yeah. Additionally, the false lumen is prone to developing thrombus, or blood clots. These clots can then embolize, meaning they break off and travel downstream, and further obstruct the opening of the branch vessel from within the false lumen.
So it's a more permanent blockage?
Generally, yes. Unlike dynamic obstruction, static obstruction typically won't resolve just by restoring adequate blood flow in the main aortic true lumen. It often requires direct intervention on the affected branch vessel itself, like stenting or surgery, to restore blood flow.
Okay, so we've covered the underlying mechanisms, the classifications, the risks, and potential complications. How does an aortic dissection actually present in a patient? What are the typical signs and symptoms that might lead a doctor to suspect this condition?
Pain. Pain is by far the most common symptom. It's reported by over 93% of patients.
That's almost everyone.
Pretty much. And crucially, for about 85% of individuals, the onset of this pain is sudden and abrupt. Just bam, it hits.
And it's severe.
Extremely.
Yeah.
A significant number, around 90%, describe it as the worst pain of their life. That's a classic description you listen for.
Where's the pain usually felt? Does it differ by type?
It can. While the pain associated with a Type A dissection is often felt in the anterior or front of the chest, pain from a Type B dissection is more frequently located in the back, maybe between the shoulder blades.
Okay.
Abdominal pain can also occur, and that should definitely raise suspicion for malperfusion affecting the mesenteric arteries, the ones supplying blood to the intestines. That's a surgical emergency.
And if the pain comes back?
Any recurrence of pain after initial treatment for aortic dissection is a red flag. It should prompt immediate repeat imaging to assess for potential complications or an extension of the dissection. You can't ignore returning pain.
What about blood pressure? I would imagine that's often affected in these cases, maybe high.
Yes, indeed. High blood pressure is quite common, especially in Type B dissections. It's present in approximately 70% of those patients.
But less so in type A.
Correct. It's less frequently seen in type A dissections, maybe only occurring in about 25% to 35% of those cases. Interestingly, low blood pressure, hypotension, is relatively rare in type B dissections, less than 5% of patients.
But more common in type A. Why?
Yes, it's more frequent in type A, occurring in around 25% of cases.
Mm.
Hypotension in type A can be a really ominous sign. It might indicate serious complications like the aortic valve being disrupted or cardiac tamponade.
Tamponade, that's blood leaking around the heart.
Exactly. Blood leaks into the sac surrounding the heart, the pericardium, and impairs its ability to pump effectively. It's life-threatening.
And blood pressure readings themselves can be misleading.
They can. Another important point is that if the arteries supplying blood to the arms are involved in the dissection, the blood pressure readings taken in the arms might be falsely low, even if the central blood pressure is high. You have to check both arms, maybe even legs.
And difficult to control hypertension.
Yes, that's also common. Hypertension that is refractory or difficult to control despite medication is seen in about 64% of type B dissections.
Our source also mentions syncope or fainting and other neurological symptoms that can occur.
Right. Fainting or syncope can occur in about 5% to 10% of patients with aortic dissection, and it can be a worrisome sign.
Why worrisome?
It could potentially indicate cardiac tamponade, like we just discussed, or involvement of the arteries that supply blood to the brain, the brachiocephalic vessels. Patients who experience syncope at the time of their dissection tend to have higher rates of subsequent serious complications.
And the spinal cord can be affected.
Yes, spinal cord ischemia, resulting from a disruption of blood flow to the spinal cord, is a recognized complication. It occurs in about 2% to 10% of type B dissections and can cause paralysis or weakness in the legs.
Are there other rarer neurological signs?
In rare instances, direct compression of peripheral nerves by the expanding dissection can lead to symptoms like paresthesias, abnormal skin sensations like tingling or numbness, or hoarseness if the nerve affecting the vocal cords is compressed. Even Horner syndrome, a specific combination of eye and facial symptoms, can occur due to nerve compression in the chest.
And what about the peripheral pulses in the arms and legs? Are they often affected? How important is checking those?
Checking peripheral pulses is absolutely critical. Peripheral vascular complications are indeed quite common, particularly when the aortic dissection involves the aortic arch or the thoracoabdominal aorta. They occur in about 30% to 50% of such cases.
Which arteries are most affected?
Specific arteries, including those supplying the arms, like the brachiocephalic and subclavian, and the legs, the iliofemoral arteries, can definitely be affected.
And what does a weak or absent pulse tell you?
The absence or significant weakening of a peripheral pulse often correlates with the presence of neurological deficits, coma, and low blood pressure. It's a sign of malperfusion. Notably, a diminished or absent carotid pulse in the neck strongly suggests an increased risk of stroke.
So more pulse deficits mean a worse outlook.
Generally, yes. Studies have shown that mortality rates are linked to the number of pulse deaths a patient has at the time of presentation. It indicates more widespread malperfusion.
Okay. Given that so many people present to emergency rooms with chest pain each year, millions probably, how do doctors actually go about diagnosing aortic dissection? You can't exactly scan everyone, right?
You're absolutely right. It's a huge challenge. With millions of individuals presenting with chest pain annually, it's simply not feasible or practical to perform advanced imaging on everyone.
So the initial suspicion must be key.
It is. But unfortunately, the initial suspicion rate for aortic dissection is often relatively low. Studies show it ranges from about 15% to maybe 43%.
Yeah.
And in some cases, the diagnosis is actually made incidentally during imaging for something else entirely.
What was the old way of diagnosing it?
Historically, aortography, which involves injecting contrast dye directly into the aorta under X-ray, was considered the gold standard,
But not anymore.
not as the primary tool. Now, non-invasive imaging techniques like computed tomographic angiography, CTA, transesophageal echocardiography, TEE, and magnetic resonance imaging, MRI, are the mainstays. Aortography is now typically reserved as an adjunct, maybe used during endovascular treatment procedures.
So when a doctor does suspect aortic dissection, what are the key objectives they're trying to achieve with the diagnostic test? What do they need to find out?
Right. The first and most crucial goal is simple. Confirm or definitively rule out the presence of an aortic dissection, yes or no. Second, if a dissection is present, it's essential to determine its precise extent along the aorta. Where does it start? Where does it end? And critically, does it involve any of the major branch vessels going to organs or limbs?
And third,
Third, the evaluation aims to identify any immediate and life-threatening complications. things like cardiac tamponade, severe aortic valve leakage, or acute organ malperfusion, those require immediate attention.
Okay, let's walk through the different imaging modalities that are available today. What specific information can each one provide? Starting with maybe a basic chest X-ray.
Sure, plain chest x-rays are often the very first imaging study obtained in patients presenting with chest pain, partly because they're quick and easy. But their findings in cases of aortic dissection are often nonspecific.
Like what?
Things like a widened mediastinum, the space in the chest between the lungs, or maybe displaced calcium deposits in the aorta, or fluid around the lungs. These could be suggestive, but they're not reliable enough to definitively diagnose or exclude a dissection on their own.
So not definitive. What about CT scans or CTA?
Computed tomographic angiography, CTA, is now a cornerstone. It's widely available, relatively non-invasive, and offers high sensitivity, meaning it's good at detecting dissections when they are present, and good specificity, meaning it's also good at ruling them out when they're not there.
Any limitations?
One potential limitation of CTA can sometimes be in visualizing the very first part of the ascending aorta, right close to the heart. But this can usually be overcome by using transesophageal echocardiography, TEE.
What makes CTA so useful?
It provides incredibly detailed cross-sectional images of the aorta. You can clearly see the true and false lumens, that intimal flap separating them, and the involvement or lack thereof of branch vessels. This detail is invaluable for planning treatment.
Are there specific things on the CTA that suggest problems like malperfusion?
Yes. A key finding on CTA that should definitely raise suspicion for malperfusion is the appearance of a compressed or collapsed true lumen. That suggests pressure in the false lumen is high. Also, interestingly, the false lumen tends to be larger than the true lumen in the descending aorta in over 90% of cases. And the way the intimal flap looks, how it's oriented, how mobile it appears, can also provide clues about the pressure dynamics. A flap that bows towards the false lumen suggests a pressure deficit in the true lumen, which, again, can contribute to malperfusion.
Okay, so CTA is a major tool. What about echocardiography? You mentioned TE, but there's also the regular kind, TTE.
That's right. Transthoracic echocardiography, or TTE, is the one performed by placing an ultrasound probe on the chest wall. It's non-invasive and readily available, but its sensitivity and specificity for detecting aortic dissection are somewhat variable.
Why variable?
It can be limited, particularly in visualizing the distal part of the ascending aorta and the aortic arch, because the ribs and lungs get in the way of the ultrasound waves.
So TE is better for dissection.
Transesophageal echocardiography, TE, involves passing a small ultrasound probe down the esophagus. Because the esophagus runs right behind the heart and aorta, you get much clearer, unobstructed images, especially the ascending aorta and arch.
And its accuracy.
T has high sensitivity, around 98%, and pretty good specificity for detecting aortic dissection. A huge advantage is that it can be performed right at the bedside, even in unstable patients in the ICU or emergency room.
What can you see with T?
You can directly visualize the entry tear, see blood flow within the true and false lumens, detect any thrombus or clots, check for involvement of the aortic arch or the coronary arteries, assess leakage from the aortic valve, and critically see if there's fluid around the heart suggesting pericardial effusion or tamponade. It's also really useful in the operating room to guide management in unstable patients during surgery or intervention.
And finally, what role does magnetic resonance imaging, MRI, play in diagnosing aortic dissection?
MRI offers excellent sensitivity and specificity for the diagnosis of aortic dissection, often comparable to, or maybe even exceeding that of CTA and T in some aspects.
What are its strengths?
It provides superb anatomical detail showing the entry tear location, the full extent of the dissection, and branch vessel involvement very clearly. MRI is also very good at differentiating between flowing blood and thrombus, or clot, within the false lumen. Its sensitivity and specificity for detecting actual involvement of the branch vessels are also very high.
So why isn't it used first line all the time?
It has some practical limitations. It's not as readily available 24/7 as CTA in many emergency settings. The exam itself takes significantly longer to perform than a CTA. And it's not ideal for critically ill patients who require continuous intensive monitoring and might not be stable enough to tolerate being inside the MRI scanner for an extended period. You can't easily have lots of lines and equipment in the MRI scanner room.
Okay, that makes sense. Let's turn our attention now specifically to the treatment of type B aortic dissections, those that don't involve the ascending aorta. What's the generally accepted optimal approach for these?
Right. The cornerstone of optimal treatment for type B aortic dissection really involves a few key things. Timely diagnosis, of course, aggressive but very careful blood pressure control, and the early recognition and management of any signs of malperfusion, that inadequate blood flow to vital organs we talked about.
Is rupture a big immediate concern like in Type A?
Unlike Type A dissections, acute rupture of a Type B dissection is actually less common unless there's already significant dilation or enlargement of the false lumen.
So the strategy is different.
It is. The treatment strategy for Type B is often tailored to the specific complications that might arise. Both open surgical repair and increasingly endovascular techniques are used to address malperfusion if it occurs.
What about surgery just to fix the tear in uncomplicated cases?
That's an interesting point. Studies have actually shown that for uncomplicated Type B dissections, meaning those without malperfusion or signs of rupture, routine open surgical replacement of just the initial entry tear has not been shown to be superior to good medical therapy alone in terms of outcomes.
So medical therapy is the starting point for uncomplicated Type B.
Generally, yes.
Got it. But our source did suggest that there's a more nuanced and evolving understanding even for those initially deemed uncomplicated Type B cases.
Yes, that's a crucial point and where things have been changing. More recent data indicates that a specific subset of patients who initially present with what looks like an uncomplicated Type B aortic dissection may actually benefit from elective treatment with TEVAR.
TEVAR being the stent graft.
Exactly. Thoracic endovascular aortic repair, placing a stent graft within the aorta to seal off the entry tear. And the timing might be best during that subacute phase, the window between 2 weeks and 90 days after the dissection first happens.
Which patients might benefit from this earlier intervention?
It seems that certain anatomical features identified on the initial imaging, things like a particularly large initial tear or a larger overall aortic diameter right from the start, these seem to be predictors of a higher risk of developing complications later on, or failure of medical management alone over the longer term. So intervening earlier in these higher-risk, uncomplicated patients might prevent future problems.
Okay, so let's talk about that medical treatment first. What does it typically involve for a Type B aortic dissection?
Right. Medical management, usually in an intensive care unit setting, is the initial treatment strategy for virtually all patients presenting with a Type B aortic dissection.
And the main goals?
The primary goals are to rapidly and effectively reduce the patient's blood pressure, and importantly, to decrease what's called DPDT. That's the rate at which the pressure rises with each heartbeat. Basically, reduce the stress and shearing force on the damaged aortic wall.
How does that help?
This helps to stabilize the dissection, prevent further tearing, and reduce the risk of rupture or the development of branch vessel compromise or malperfusion.
How is it done?
This requires continuous, close monitoring of the patient's vital signs, heart rate, blood pressure, often with an arterial line for real-time readings, and the administration of intravenous antihypertensive medications.
What kinds of medications?
Beta blockers are typically the first-line drugs. They help reduce the heart rate and the force of the heart's contractions. These are often followed by vasodilators, like sodium nitroprusside or nicardipine, to further lower the overall blood pressure. It's usually important to start the beta blocker before the vasodilator.
Why is that?
Because if you just dilate the blood vessels without controlling the heart's force first, you can actually increase the shear stress on the aortic wall, which is the opposite of what you want.
Got it. What's the target blood pressure?
The target systolic blood pressure is generally kept low, often between 100 and 120 millimeters of mercury, with a mean arterial pressure ideally around 60 to 70 millimeters of mercury. Basically, the lowest pressure that still allows adequate organ perfusion.
And then long term?
Once the patient is stable and the dissection seems controlled, they're transitioned to oral antihypertensive medications for long-term management. Lifelong blood pressure control is crucial.
Is medical management always successful initially?
Not always. Even after achieving good blood pressure control, close and ongoing monitoring is absolutely essential because some patients can still develop early complications despite seemingly adequate medical therapy. You have to watch them very carefully in the ICU.
And follow-up imaging?
Yes, serial surveillance imaging, typically with CTA scans, is a critical component of medical management. Usually a scan is done before the patient leaves the hospital, then perhaps at 6-month intervals for the first year, and then annually after that, assuming the dissection remains stable.
What are the outcomes like with just medical management for uncomplicated Type B?
Well, the 30-day mortality rate with medical management of uncomplicated Type B dissection is actually relatively low, around 10%, which, interestingly, is often better than the mortality reported for acute open surgical repair in many older series, which could be closer to 30%.
So medically managed patients do reasonably well short-term?
Short-term, yes, if they remain uncomplicated. However, A significant long-term concern is the potential for aneurysmal degeneration or enlargement of that false lumen. This can occur in up to 40% of patients over time, even with good medical therapy.
So the aorta can still expand dangerously later on.
Exactly. Long-term data has shown that a substantial proportion of patients initially managed medically will eventually need some kind of intervention later on, or unfortunately die due to aortic-related complications. And aortic growth, some degree of enlargement, is seen in almost half of these medically managed patients by 5 years.
Okay. So when would open surgical repair be considered for a type B aortic dissection? It sounds like it's less common in the acute phase compared to type A.
That's correct.
Mm-hmm.
The indications for doing an acute open surgical graft replacement in a distal, or type B aortic dissection, are relatively rare these days.
What would be the main reason?
The primary scenario would be a threatened or actual rupture of the aorta, usually happening right at the site of the initial tear in the proximal part of the descending aorta, especially if there isn't an adequate length of undamaged aorta nearby what we call a proximal neck to serve as a safe landing zone for an endovascular stent graft, or TEVAR.
And how extensive is the surgery usually?
Unless there's already a large aneurysm present in that segment, surgical repair in the acute setting should generally be limited just to replacing the proximal descending aorta where the tear is. Trying to do a more extensive replacement in the acute phase carries significantly higher risks of mortality and, importantly, spinal cord injury, which can lead to paralysis.
What are the reported risks of open surgery for acute type B?
The mortality rates reported in the literature for open surgical repair of acute type B dissections vary quite widely, historically ranging anywhere from around 6% to as high as 69% in some older series. More recent data from large registries like IRAD have helped clarify the risks, but it remains a high-risk operation in the acute setting. And as I mentioned, the risk of spinal cord injury is a major concern with open repair of the descending thoracic aorta.
Okay, that brings us clearly to endovascular treatment, specifically TEVAR, for type B aortic dissections. How has this approach really changed the management landscape?
Thoracic endovascular aortic repair, TEVAR, has truly revolutionized the treatment of type B aortic dissections, especially the complicated ones, but increasingly the uncomplicated ones too.
What are the main goals when performing TEVAR for dissection?
The primary goals are, first, to deploy a covered stent graft across the initial entry tear in the aorta, effectively sealing it off from high-pressure blood flow.
Seal the leak, basically.
Exactly. The sealing ideally promotes thrombosis or clotting within the false lumen downstream. If the false lumen clots off, this can allow the compressed true lumen to re-expand, which helps restore adequate blood flow to the vital organs that branch off it. And over time, this process can potentially promote positive aortic remodeling, meaning the aorta might shrink back towards a more normal size and shape.
And preventing future problems.
Yes, a key long-term aim of TEVAR is to prevent that late development of aneurysms in the dissected segment of the aorta, which we know is a risk with medical management alone.
Was TEVAR always used this way?
Initially, TEVAR was primarily used for complicated type B dissections, those involving malperfusion or signs of rupture. But as the technology has improved and experience has grown, its role in managing even initially uncomplicated cases, particularly those high-risk ones we discussed, is increasingly being recognized and studied.
And you mentioned achieving thrombosis, clotting of the false lumen is really important in the long run. Why is that considered so crucial?
Because a persistently patent or open and flowing false lumen is a well-established independent risk factor for bad things happening later on. Specifically, the development of aortic aneurysms and other late complications related to the dissection, including rupture.
So an open false lumen is bad news long-term?
It seems to be. Studies have shown that in a significant percentage of patients managed just medically, the false lumen can actually enlarge over time, even if it looks stable initially. Furthermore, even having just partial thrombosis or clotting within the distal false lumen has been linked to a higher risk of mortality after the patient leaves the hospital.
So TEVAR tries to shut it down completely.
Exactly. TEVAR aims to induce complete thrombosis of the false lumen, ideally starting right from the stent graft downwards, to mitigate these long-term risks and promote more stable, positive aortic remodeling.
What are some of the critical technical aspects involved in actually performing a TEVAR procedure for aortic dissection? It sounds complex.
It requires meticulous technique and very precise planning. There's less room for error than in treating simple aneurysms. First, you absolutely need to use covered stent grafts to effectively seal off the entry tear. Uncovered stents won't work for this purpose.
Okay, covered grafts. What else?
Accurate identification of the exact location of the entry tear on imaging is paramount. And ensuring there's an adequate length of relatively normal, undiseased aorta proximal to the tear, the landing zone, is absolutely critical for the procedure's success and to prevent leaks around the top of the graft called endoleaks.
Does getting that landing zone ever cause issues?
Sometimes. Achieving that good proximal seal often necessitates intentionally covering the origin of the left subclavian artery, one of the major vessels branching off the aortic arch. This is often required to get enough length for the graft to seal properly.
And covering that artery is okay.
It often is, but it requires assessment beforehand, and sometimes requires a separate bypass procedure to maintain blood flow to the left arm and parts of the brain if needed.
Where is the procedure done?
It's typically performed in a specialized operating room or hybrid suite, equipped with high-quality fluoroscopy, which allows real-time X-ray visualization.
How do you get the stent graft in?
Access to the true lumen of the aorta is usually obtained through an artery in the groin, the femoral artery. Sometimes access through the arm, the brachial artery, is used, especially for type B dissections, as it can allow for better control and visualization near the aortic arch.
Is imaging used during the procedure?
Definitely. Intravascular ultrasound, or IVUS, is frequently employed. This involves putting a tiny ultrasound probe on a catheter inside the aorta.
What does IVUS show?
It gives a real-time cross-sectional view from inside the vessel. It's invaluable for confirming that you're definitely in the true lumen, not the false lumen, for precisely positioning the stent graft, and for assessing its relationship to the crucial branch vessels. It helps avoid accidentally covering important arteries.
How much length do you need for the seal zone?
Ideally, a proximal seal zone of at least 2 centimeters in length is desired for stability.
And how much of the aorta do you cover?
To minimize the risk of paraplegia, or spinal cord injury, which is still a risk with TEVAR, though generally lower than open surgery, the length of the aorta that is covered by the stent graft is generally kept to the minimum necessary to effectively seal the primary entry tear and achieve a good proximal seal. You don't want to cover excessively long segments if you can avoid it.
What happens after the graft is deployed?
IVUS is often used again after the stent graft is deployed to assess how well the true lumen has expanded and to look at the mobility of the intimal flap. You want to see the flap pushed against the aortic wall.
Do you balloon the graft open aggressively?
Generally, it's important to avoid over-aggressive ballooning of the stent graft, especially at the proximal seal zone, in acute dissections. There's a concern that this could potentially increase the risk of causing a new tear or extending the dissection backwards towards the heart, which is called a retrograde type A dissection, a serious complication.
Okay, so what kind of outcomes are being observed with the use of TEVAR for type B aortic dissections? Is it working well?
Overall, the short-term results for symptomatic acute type B aortic dissections treated with TEVAR have been quite promising.
How does it compare to medical therapy for uncomplicated cases?
Studies, including large registry data like that from the International Registry of Aortic Dissection, IROUT, have shown similar, relatively low in-hospital mortality rates for TEVAR compared to medical therapy alone in patients with uncomplicated type B dissections treated acutely.
And for complicated cases? For
complicated type B dissections, those with malperfusion or rupture, TEVAR has become the standard of care in many centers. Major trials like the GORTAG 0801 study demonstrated low 30-day mortality rates with TEVAR in this group, although that particular trial did note a slightly higher incidence of stroke compared to historical controls, highlighting a potential risk. The STABLE trial also reported favorable early outcomes.
Are there good data summaries available?
Yes. A report from the Society for Vascular Surgery, SVS Outcomes Committee, specifically looked at TEVAR for complicated type B dissections and provided valuable benchmark data on mortality, stroke, and paraplegia rates, which helps centers evaluate their own results.
And the long-term benefits. You mentioned remodeling.
Right. The true long-term benefit of TEVAR really depends on achieving that durable seal, getting complete thrombosis of the false lumen, and promoting positive remodeling of the aorta, getting it to shrink down or at least stop expanding.
Is that happening?
Several important studies have tracked this over time. They provided data on the rates of false lumen thrombosis and aortic remodeling at both 1 year and 5 years following TEVAR, and the results are generally encouraging in appropriately selected patients who get a good initial result. But long-term surveillance is still absolutely necessary.
You also mentioned earlier the specific treatment of malperfusion syndrome when it occurs. That's a complication in maybe 25–40% of cases. How is that typically addressed? Is it always TEVAR?
Not necessarily just TEVAR, although TEVAR to cover the entry tear can sometimes resolve dynamic obstruction. when malperfusion syndrome complicates an aortic dissection. The specific treatment approach is really dictated by the anatomical findings on the CT scan. That helps determine the underlying mechanism. Is it dynamic or static obstruction, and which vessels are affected?
So what are the options, especially endovascular ones?
Endovascular treatment options are often preferred if feasible. This typically involves gaining catheter access into both the true and false lumens of the aorta, if possible.
And using IVUS again?
Yes, intravascular ultrasound, IVUS, is again invaluable here. It's used to map out the relationship of that intimal flap to the origins, the ostia of the visceral and renal arteries, all the way from the ascending aorta down to the iliac arteries in the pelvis.
Then what?
Selective angiography injecting contrast dye directly into the suspected branch vessels under X-ray is then used to further delineate the problem and confirm the blockage.
Do you treat the branch vessel or the aorta first?
Usually, if a specific branch vessel is found to be compromised, placing a stent directly into that vessel's origin is performed before considering any direct intervention on the main aorta itself, like creating a fenestration. You want to restore organ perfusion quickly.
What about fenestration? What is that exactly?
Percutaneous fenestration involves intentionally creating a controlled opening or tear in the intimal flap between the true and false lumens of the aorta.
Why would you do that?
The goal is often to equalize the pressure between the two lumens, or to allow blood from the higher pressure false lumen to flow back into the true lumen, thereby improving blood flow down the true lumen to the organs.
How is it done?
Several techniques exist for performing percutaneous fenestration, usually guided by both ultrasound and fluoroscopy. Typically, it involves using a special needle and wire to puncture the flap, followed by balloon dilation to enlarge the opening. Sometimes a stent is then placed across the fenestration itself to keep it open.
What are the results like for fenestration?
Data from various studies have shown reasonable 30-day mortality rates with percutaneous fenestration for malperfusion. But long-term reintervention rates can be a consideration. Sometimes those fenestrations can close off again.
Is open surgery ever needed for malperfusion?
Yes, open surgical treatment for malperfusion is sometimes necessary, but less common now with advanced endovascular skills. The most common open procedure specifically for dynamic obstruction is surgical fenestration.
How is that different from percutaneous?
It's a much bigger operation. It involves surgically opening the aorta and actually cutting out a large section of the septum, or intimal flap, separating the true and false lumens to widely connect them.
Where is this done?
This surgical fenestration might need to be extended down into the visceral aortic segment, the part with the organ arteries, to allow for direct inspection and possible repair of the branch vessel origins. Clamping the aorta above the organ arteries is generally avoided or kept very brief due to the risk of organ damage.
Any other open options?
Placing an infrarenal bypass graft. A graft below the renal arteries can sometimes facilitate the connections during open repair. And direct surgical repair or bypass of statically obstructed branch vessels is also possible in some situations. A left flank approach through the side is often preferred for getting good exposure to that visceral aortic segment. But again, open surgical fenestration is needed relatively infrequently now, although when performed appropriately, it can offer durable relief of malperfusion.
Okay. Finally, let's talk about the long-term picture. What does the natural history of aortic dissection look like for survivors, and what kind of follow-up is typically required? It sounds like it's not over once you leave the hospital.
Absolutely not. It's a lifelong condition requiring surveillance. The primary late complication we worry about following aortic dissection is the development of aneurysmal dilation or enlargement, particularly of the false lumen.
How common is that?
It can occur in a significant proportion of survivors, perhaps 25% to 50% in some studies, even with good ongoing medical management. Chronic aortic dissection is actually a contributing factor in about 20% of all thoracoabdominal aneurysms that eventually require treatment.
And how quickly does the aorta grow?
Long-term data, like from Duke, has shown that only about half of patients with medically managed Type B dissections are actually free from any aortic growth at 5 years. So growth is common.
Leading to more interventions.
Yes. Alarmingly, nearly 30% of these medically managed patients will eventually require some kind of intervention, most often open surgical repair, specifically for aneurysm degeneration later on. And operating on aneurysms that arise from chronic dissections can be technically very challenging.
Are there ways to predict who is at higher risk for this late aneurysm formation?
Yes, several risk factors have been identified. These include poorly controlled hypertension, obviously. Also, having an acute aortic diameter of 4 centimeters or greater at the time of the initial dissection, Persistent patency, or flow, in the false lumen is a big one, having a proximal entry tear that's large, maybe 10 millimeters or bigger. And, interestingly, having partial thrombosis of the distal false lumen seems to be a risk factor too, perhaps because it creates disturbed flow patterns.
And these are the patients who might benefit from earlier TUVAR.
Exactly. Patients who present with these high-risk features, even if they are initially uncomplicated, may particularly benefit from consideration of elective TUVAR during that subacute phase to try and prevent this late degeneration.
What about late rupture?
Late rupture of the dissected aorta is a real and feared complication. It can occur in maybe 10% to 20% of patients over the long term if the aorta continues to dilate.
Does intervening earlier with TUVAR improve long-term survival?
That's the key question, and the data is evolving. The INSTEAD trial was important here. It compared early TVAR versus medical therapy alone for stable, subacute, and chronic uncomplicated Type B dissections. It showed superior 5-year survival with TVAR, although interestingly, there was no significant difference seen at the 2-year mark.
What about data for acute dissections?
Data from the IR registry has also seemed to support this trend towards better long-term survival with TVAR compared to medical therapy alone, even when initiated in the acute phase for Type B dissections, although registry data has its limitations.
What about patients managed medically who then need intervention later?
Interestingly, some studies have shown potentially better survival in those medically managed patients who eventually required an intervention for a late complication compared to similar patients who remained on medical therapy alone and never got an intervention. This suggests that timely intervention for late complications when needed can definitely improve outcomes.
What are the main causes of death long-term?
Analysis of cause-specific mortality has shown that aortic-related deaths rupture, complications of surgery or intervention contribute significantly to shorter overall survival in patients who have had an aortic dissection.
So what's the bottom line for long-term care?
Well, given these long-term risks and the fact that aneurysms arising from chronic dissections tend to be more extensive and often occur in relatively younger patients, effective long-term medical management is absolutely essential. This includes aggressive blood pressure control. The target is generally less than 125 over 80 millimol Hg and even lower for individuals with Marfan syndrome.
And beta blockers remain important.
Yes, lifelong beta blockade to control heart rate and blood pressure is crucial. Beta blockers have been shown to slow down aortic root growth in Marfan syndrome, and it's thought they may have a similar beneficial protective effect on the thoracoabdominal aorta in patients with dissection.
And the need for ongoing imaging?
Absolutely. Lifelong serial imaging of the entire aorta, usually with CTA or MRA, is the cornerstone of long-term follow-up. You have to think of aortic dissection as a systemic illness affecting the entire vessel. You need to watch the whole thing over time.
What about future treatments for these complex chronic cases?
Branched and fenestrated stent graft technologies, grafts with built-in holes or branches for the organ arteries, hold significant promise for the future treatment of complex chronic dissection aneurysms that involve the visceral or renal arteries, potentially offering less invasive options than complex open surgery. That's an area of active development.
Our source even includes a helpful algorithm, a kind of flowchart, for approaching a patient with acute chest pain that might be aortic dissection. Can you quickly walk us through that logic?
Yeah, absolutely. The algorithm provides a really logical step-by-step approach. First, if someone comes in with acute chest pain and maybe hypertension, you do an initial cardiac evaluation to quickly rule out a heart attack, get an ECG, check cardiac enzymes. Then, if suspicion for dissection remains high, you move to a focused evaluation specifically for aortic dissection, using the imaging modalities we discussed, maybe chest x-ray first,
Right.
but then quickly onto CTA or perhaps T if the patient is unstable, or CTA is inconclusive for the ascending aorta.
And once the diagnosis is made,
Based on the classification determined by the imaging, is it Type A or Type B? The management pathway diverges sharply.
Type A goes where?
Type A dissections, because they involve the ascending aorta and pose an immediate threat to the heart, typically require immediate consultation with cardiac surgery and usually emergent surgical intervention to replace the ascending aorta.
And Type B?
For Type B dissections, the next crucial question is there evidence of malperfusion or rupture? If the answer is no, it's an uncomplicated Type B, then medical treatment in the ICU focused on heart rate and blood pressure control is usually the initial strategy, coupled with close observation.
But if there is malperfusion or rupture?
However, if malperfusion is present, or if there are signs of impending rupture, then urgent repair is indicated. This could involve TVAR to cover the entry tear, possibly combined with endovascular fenestration or branch vessel stenting to improve blood flow to the ischemic organs, or in select cases where endovascular options aren't suitable or fail, open surgical repair might be necessary.
This has truly been a deep dive into the complexities of aortic dissection. It's clear it's a condition with incredibly high stakes that really demands swift diagnosis and precisely tailored management.
Absolutely. As we've discussed, the different classification systems, Stanford, DeBakey, acute, subacute, chronic, they provide crucial frameworks for guiding those treatment decisions.
Yeah.
And understanding the various risk factors, some of which might be surprising, like the time of day or cocaine use, is really key for both patients and clinicians. The diverse ways in which aortic dissection can present clinically, sometimes mimicking other conditions, underscores the importance of maintaining a high index of suspicion.
And the treatment has really changed.
It really has. The significant advancements in treatment, particularly the increasing role of endovascular options like TVAR for Type B dissections, represent a major step forward in improving outcomes for this historically lethal condition.
It's also just a powerful reminder, isn't it, of the continuous progress in medical knowledge. It's driven by ongoing research and the invaluable insights we get from large patient registries like IARD and those pivotal clinical trials that constantly refine our understanding and our approaches to treating this really challenging condition.
Absolutely. What's particularly compelling, I think, is the way these collaborative efforts sharing data and experiences globally are constantly shaping and refining our clinical practices, often in real time. It's a dynamic field.
So, as you've listened to this deep dive today, considering the often silent nature of some of the risk factors for aortic dissection, like maybe underlying high blood pressure you didn't know about, or a connective tissue issue, and the potential for such severe and rapid consequences, it really makes you think, doesn't it? What proactive steps might be worthwhile for you in terms of increasing your own awareness of your cardiovascular health? Perhaps it's a good time to explore some of the references we've mentioned if you want more detail, or maybe just have an open conversation with your own healthcare provider. You could gain personalized insights into your individual risk factors and discuss what preventative measures might be appropriate for you.